Okay, we're to module 6. This is the policy part. I'm gonna run this part, even though you wrote them, which is okay. But I think from a provider medical director perspective, I think I'm talking to the clinicians that I work with.
Absolutely.
So I'm going to run you through these, but just to give you kind of some high-level overviews, there are 22 policies. That seems like a lot that either directly or indirectly relate to our TAD program. There are 7 policies that are brand new, and there are 9 that we're going to cover in this particular training. And the reason why these 9 are selected is because they most directly apply. We're not going to talk about all 22 policies, and then we're going to go through a little bit on documentation, and then we're going to finish up with an EMTALA discussion.
That's right.
And we're going to give you guys back your day.
Yes.
All right. Okay, so the first one is on patient privacy. This is not a new policy. This is a policy that's been around for a couple years, but it's just an opportunity to remind you about a couple of things. So protected health information. And when I was kind of developing this part of the talk, my brain went to the cameras that come out at certain calls, right? And they take pictures of different things that happen at calls. And we just want to remind you that any kind of information that comes from a patient, whether it's written or it's media or it's something that actually can be traced back to an individual, there's a reasonable basis to believe it can be used to identify an individual. That by definition is called protected health information, right? And so we don't want any of this information floating around out there, especially about these individuals involved with the TAD program. Right, and so just a reminder that possessing, releasing, or discussing any of this protected health information is a violation of what's called the Health Insurance Portability and Accountability Act, or HIPAA. We all know what HIPAA is out there. I know you've all had it in school and in your training, but this is an opportunity to remind you, just be responsible.
Absolutely, and when in doubt, it's protected. And just keep it protected. Just think about this, every patient that you encounter as this is a family member, and would you like their information to be splashed out there into the world? Just do what you know is right. All right. So the next one is one that's near and dear to all of our heart. It's the patient-initiated refusal of EMS assessment, treatment, and transport. This one has also, it's not a new policy, but it's just an opportunity to go over some key elements to remind, because remember, this is a TAD program where these are patients, so we're going to be going through like what is this patient, and by the way, these are all patients, right? None of these folks are defined as a person, which person actually isn't in our policy anymore, because we feel like the only people we treat are patients, right? So anyway, I'm going to go through this flow diagram just one by one, but this diagram, as you know, it's lengthy, but I think it's helpful because it does break it out into kind of 4 key sections. The first one is patient refusal of EMS assessment, treatment, and transport is the entry lane for a patient that has a complaint or a condition that can be viewed as having a medical or traumatic emergency. And so after you obtain your physical, including your vitals, you've gotten your medical history, you've done your history, and the patient is now refusing assessment, care, or transport at any point along this. So that is our entry lane. We are in this policy now. We have someone we've assessed, they don't want anything to do with us. And they throw out the flag.
They throw up the flag. So a couple things, they have to be 18 years or emancipated to do it on their own, right? And so a legal guardian or a person who is legally responsible for them can do it on their behalf, right? So this is an individual that has the capacity to make these decisions, but that gets us to the question of capacity.
That's right.
Right, and so capacity is a person has the ability to understand and comprehend the gravity of the decision that they are personally making to refuse further care, treatment, assessment, and transport.
And they're able to understand, and oftentimes I ask them to tell me. So what is the possibility if you were to walk away? If you were not to be treated, transported, or seen in an emergency department, what could happen to you? I could die. Yes, that's the up to and including death as a potential pathway if you were to not get care.
Absolutely. But there are some that don't have capacity and literally cannot refuse.
That's right.
And just, this is a short list of them, but just, they're kind of intuitive, right? They have a head injury, they're hypoxic, they're hypoglycemic. Altered, right? The capacity part, like, can they understand this? A person who's a danger to themselves or to others, a person who's actively suicidal.
A trauma patient with a blood pressure of 70.
Right, exactly. So these individuals don't have the ability to understand what the gravity of their decision is, and therefore they lack capacity. And they really, at that point, they shouldn't and they can't refuse, but there are some who will still refuse. So any of these individuals that do not have decision-making capacity, there is implied consent and they should be transported to a hospital. Now let's assume that none of these conditions exist. They're an adult, they have capacity, they do have the right to refuse. Yeah. Right, and there's a process for that. You obtain your signatures, and I would definitely clearly document your conversation in the narrative as well about their decision to refuse. So individuals can refuse, assuming none of these conditions are present. Now, if you transfer to the other side, right, and so this is someone who doesn't, who is either not old enough, right, or doesn't have,
or you're dealing with a guardian.
Or dealing with a guardian, right? And so in this case, if the parent or the legal guardian consents to not having any further assessment, treatment, or transport, then that's that person's right, and that's the person that signs the refusal. However, if you are able to contact, if you feel like this person needs to go and you're not able to contact the parent or legal guardian, this is where base contact comes in. So don't forget that base contact is a key part of the refusal process if you need that extra resource. And medics ask me, like, why? Like, what's the purpose of the base contact? Because they're not there. And really, this is to have an advocate for you, that because you feel this person needs to go, and that person can sometimes help you in that side. But it's also to get this conversation in another format that's recorded.
Right.
Yeah, right. It's really important to have these individuals recorded saying what they're saying, because that'll also demonstrate capacity in their understanding. When they call us, and I'm a base physician and I talk to them on the phone, I do ask them some questions that establishes their capacity.
Right. Do you understand what not going could mean?
Yeah, and so it's really a backup for you. Okay. And then at the bottom, there are some definitions about decision-making capacity against medical advice. This policy has been in place for a while. You guys can all go through these boxes at the bottom about refusal of service and the pearls and things like that. Establishing the legal ability to sign for a patient, obtaining your signatures and all that stuff. So that kind of covers that.
Absolutely.
Anything else in here?
No, I think that the policy, like you said, it's been in place for quite some time. I know it's used effectively in the field. I get these calls as well when I'm working in the ED, and it's just document. I think that's the bottom line. Just be protecting yourself. Go through the steps. So there's a clear understanding that the conversations were had, and that the person or the legal guardian made the decision they made, and had the capacity to do it.
Yeah, and at the end of the day, if you're still uncomfortable, making that base contact as well can also help you.
Absolutely.
All right, electronic health record and data policy. This policy has also been around for a while. Basically, in a nutshell, every provider participating in TAD must use an electronic health record that is both NEMSIS and CHEMSIS compliant. We already do that.
Yeah.
This isn't something you have to worry about. This is something that your employer is already taking care of. And that data upload in that really needs to be as close to real time as possible, but no longer than 24 hours. So that policy is kind of self-explanatory.
Right, and it just gives everybody an opportunity to have visibility on the patient. So particularly if that patient were to get sick while they went to an alternate destination site, we want to be able to see kind of what happened, so that we can make adjustments. And that's always the fundamental backstop of a quality improvement plan.
Yeah, absolutely. Okay, destination 50/50. I think we're on version 19 of this. This one's been around since 93. But in a nutshell, in a short, this policy's got 4 major sections. It's got a policy section, a considerations for destination decision. It's got capturing APOT section and a transfer to waiting room. I'm going to skip the transfer to waiting room part because I've covered that ad nauseum, I think, and I think I talked about it in the last training video for the county. But basically, the policy section, which is the very first section, is just a decision tree. Does a person meet any special triage criteria? Like, do they have a STEMI, stroke? Do they need to go to a facility like that? Is there a high likelihood of them requiring specialized services, and they're not meeting any other criteria? And then those are the first 2 decision points. So STEMI, stroke receiving center, they go there. Do they require specialized services? And I'm going to take a pause here and maybe go out on a limb a little bit, because we see patients transported to hospitals sometimes who have chest pain because you're a STEMI center, a cardiac center, right? All hospitals are able to handle all things.
That's right.
It's ideal that a person shot in the chest ends up at a trauma center, right? But a person that has a shoulder dislocation
Doesn't need to go to a trauma center.
does not need a trauma center.
Patients that have chest pain that don't have a STEMI on their EKG don't need to go to a STEMI receiving center. So you're absolutely right. We want to be making sure that people who are in need of specialty care go to the specialty care centers, but people who do not, they can go to any general acute care hospital emergency department in the county.
Yeah, and we could probably spend an hour on this. We really could. And it's not that this is any disparaging remarks about our clinicians, because you're really making a decision in your eyes of what's best for the patient. Right. And that's phenomenal. But the downstream effects of that are pretty detrimental both to the patient and to the system that you wouldn't ever see because you don't see what happens downstream after that.
That's right. So keeping our overall system capacity available to take care of the daily volume of patients, it sits above all of our heads, but making these choices in the way that we've set up 50/50 builds capacity and gives us the opportunity to be getting patients into the EDs, keeping our APOT times down, making sure that you guys are back on the street as quick as we can, and just it's what's best for patients.
Right, absolutely. And then all others go in this order. So this is kind of a new thing. It did change recently. And that is, don't forget, if you didn't meet the first 2, then the third one is, does a patient have a home? In other words, what I mean by that, a medical care home. Are they a Dignity patient, a Sutter patient? They go to UC Davis. And sometimes the best way to ask that question is where do you receive your care? Where does your doctor want you to go? Where like asking that question to try to get at, like, what hospital do you normally go to get your care?
Right. Well, and even understanding your primary care doctor, are they affiliated with a healthcare system? Because that'll typically be a good indicator about where to go to. Yeah,
because sometimes patients are frustrated with their own, and they go, well, I've been to Kaiser because I'm frustrated with another system, and they go, take me to Kaiser, right. Or it doesn't matter, right? And that's not the decision point. That's not an argument you need to get in the middle of. This is taking them to their home system, and then after that, if they don't have one, then it's patient or guardian preference, and then it's private MD request, and then law enforcement, kind of in that order as you're going down the chain. So just a few special considerations. Remember, for the VA, veterans go to the VA center at their request, okay? And also that rare cardiac arrest, adult cardiac arrest, goes to the VA, but that's it. That's it, okay? Law enforcement is responsible for patients in custody, and this is just an opportunity to remind you that the patient can refuse care, but they cannot refuse transport if they're in legal custody.
Right.
right? And so they can refuse you to touch them and to do anything that they want. That's their right. But they can't say, I'm not going to the hospital. That's not up to them. And then use base contact if your patient is too unstable to go to their designated facility. Don't forget that a cardiac arrest with a shockable rhythm goes to a STEMI receiving center. And then trauma with no airway. What that means is inability to oxygenate and ventilate. You have to do both, right? Goes to the closest facility, trauma or not.
That's right. So that's the shelter in the storm kind of situation where you need help with an airway.
Yeah, with a very difficult airway.
That's right.
All right, so quick word about capturing APOT times. There's a start clock and a stop clock. That start clock is when, usually it's an electronic time stamp of when transport arrive happens. That's typically in the ambulance bay. And the clock stop time is when transfer of care has happened and you've obtained a signature and you're free and unencumbered from responding on the next call. Got that right?
Exactly right.
Okay, all right. All that has to happen, right? Standing there and not getting the signature, or getting them off the bed, not getting the signature, or getting the signature, they're still on my bed, I still can't go. That doesn't stop a clock.
That's right. And we want to be making sure that when you get that patient off of your EMS apparatus, get the signature. And our ED staff are now being more aggressive about getting the signatures because that's stopping the clock for them. But we want to show that we're being good stewards of our APOT time in the county and getting that signature and seeking it out so that we can do what's right.
Yeah, and I will say, because you're here, like our APOT times are better than they've ever been, thanks to the great work that Dr. Can's done, but also the partnership with our hospitals. Our hospitals have come alongside us, and they have tackled this problem with us in a proactive way, and I think we're making progress.
Absolutely.
Awesome. Transport guidelines to sobering center facilities. So this is a brand new policy. Okay, so important initial considerations is you have to have been a person who went through this training before you can even use this
Received county accreditation in triage to alternate destination.
Yep. Number two, only facilities formally approved as TAB receiving centers are eligible to receive these patients.
And currently, at the time that we're filming this, that's Sierra Vista Hospital, that's Sac County Mental Health Treatment Center for behavioral crisis, and then WellSpace downtown on 7th Street is our designated sobering center.
So we have some centers that are coming online. I think there's probably more that'll probably come online.
Absolutely.
Okay, so the patient request to go to an acute care hospital instead of a TAD facility will have their wishes honored. So that means even if they meet all the criteria and you offer them this and they go, take me to the ER, take them to the ER, right? That's where they're going to go. Please document that. Right, because it would be helpful to follow that this has gone to an alternate facility but chose not to, because I think that's an important statistic to know.
Oh, it absolutely is, because as we continue down this program, there will be public outreach, there will be other things that we can do to educate the public that this is not punitive, and that it's a best practice for them to be following.
Right. And then if your patient's condition changes en route and they fall outside the TAD criteria, then take them to an acute care hospital, to an ER. All right, so these are the green light inclusion criteria. I'm going to go through these kind of quick because I'm going to show you this great tool that you gave us. So basically, this is for the sobering centers. This is a person who appears to be under the influence of alcohol or drugs. They're greater than or equal to 18, so 18 to basically 64. 18 to 64 is our age range. The vitals are normal. You can see them right here, but basically a systolic blood pressure of 110 to 180 and a diastolic blood pressure less than 110. Their pulse rate is greater than or equal to 50 and less than 110. Respiratory rate 10 to 20. O2 sats greater than or equal to 94% on room air. They have to have a GCS of 14 or 15. We've talked about that through this training. They have to voluntarily want to go. They have to be ambulatory, and if they're diabetic, their blood sugar has to be greater than or equal to 60 and less than 350. Yeah, and so spoiler alert, these are the same criteria used for the behavioral crisis.
Absolutely, and we've made sure that this vital signs deck here is consistent across all of our 50-50 waiting room policies. So again, you don't have to remember separate sets of vital signs parameters for who's stable. You can remember one set, and that'll guide you through all of these policies.
Red light conditions, folks that can't go, any emergent condition, active chest pain, abdominal pain, they had syncope, fall with a head strike on blood thinners. Okay, bruising above the clavicles, as we talked about earlier, receive naloxone or receive narcotic analgesia.
Right.
Yeah, if we gave them some fentanyl or some sort of medication to control their analgesia that's a narcotic, then they can't go. If they have any focal weakness, we're thinking stroke criteria here. If they ingested a toxin, if they have open or bleeding wounds. Well, I mean, what does that mean? So if they have a scrape or they fell and they've got a scrape on their elbow, right? That's not really what we're talking about with open wounds.
No, I think this is, you're going to have to use your better judgment on this. Is this somebody that just has an abrasion that needs to have a Band-Aid or a bandage put on there? That's somebody that would still fit within the TAD parameters.
Yeah.
But if they've got an open laceration that needs to be fixed, that's going to need to go to an emergency department.
Yeah, or like a diabetic foot ulcer that could be deeper and like affecting their bones, things like that.
Right.
This is it won't be subtle. It'll be fairly obvious. If they have a GI bleed, special medical equipment, if they're agitated or they're dangerous, and that means dangerous and agitated behavior. Like if it's kind of cueing you and your spidey senses, don't take them, right? In Stanislaus County, I said if it took 5 law enforcement officers to get them to be compliant, probably not a good place to go. Probably not a good patient. Yeah. If they have any intellectual or developmental delay that's obvious that you can pick up on, and then if they're pregnant as well. So again, this is a lot of criteria to remember, but fortunately, we have a sheet. And you see on the left-hand side of this picture, it's like a pilot checklist.
Yeah.
Right? And that's basically exactly what this is. And I am very hopeful that there is a tool built by the providers that choose to do this program, be it on paper, be it electronic, but some way that they equip their providers in the field, the clinicians, with a checklist.
Right. So why is air travel safe? Why are there not a ton of surgical complications with people with operating rooms? Is because they use checklists. Yeah. So it's the checklist manifesto. So I'm going to use a checklist every time to run through it. And just like you can imagine a pilot and a co-pilot, does this patient have appropriate vital signs? Yes. Are they pregnant? No. All the way down through all the things that we just spoke to. And that's going to give us an opportunity to just have that final safety check before a patient goes to a TAD site.
Yeah, and this is also going to provide coverage for you because this is either going to be electronic and live in the electronic health record, or it's going to be a piece of paper with a picture that now lives in the electronic health record. So there will be documented proof of the fact that this form doesn't have any patient identifying information on it. So you need to make sure that you attach this form to the appropriate record.
Right.
All right. Now let's flip the coin, go to mental health. Facility designation, they're strangely similar. But again, in the initial consideration section, what is mental health crisis? I think we've gone through that.
We've gone through that, yep.
Mental health emergency, we've gone through that. What is an authorized mental health facility patient triage criteria? We're going to go through that. And what are the exclusion criteria? So rather than go through all of this, since this course already went through it, I'll skip through some of the initial stages of what is a mental health crisis and a mental health emergency. Although you can read them for yourself, that basically it crosses from a crisis to an emergency when they start to act on, or they're starting to do something, or they're disoriented or erratic. Right. In those situations, or imminent threat to you and the personnel that are there. Green light criteria are identical. Just like we talked about.
But the one thing
is the voluntary,
voluntary. So if somebody's, hey, I'm having a bad day, I'm feeling suicidal, I would like to go get seen. This is somebody that could go to a mental health facility. Yes. But the flip side of this is they've been seen by police, they've been put on a 5150 hold. If there's no medical need, they fit the criteria, they can also go.
100%. Yeah. And these patients all are, your primary impression is a behavioral crisis. Right. So your primary impression is not, repeat not, chest pain, abdominal pain, syncope, whatever, fill in the blank. and then they end up at another facility, right?
Right.
You have to be in the lane of, and I say that way kind of very tongue-in-cheek because sometimes the primary impression gets to be very creative. You read the narrative and you go, oh, I think I know what I'm dealing with here, and you look at the primary impression and go, what? And so be very careful. Pick the appropriate primary impression.
Right.
And then the red light conditions,
Same thing.
and we got a checklist
For that too.
as well. All right, so a little bit about behavioral crisis and restraint. Again, not a new policy, but a couple of little nuance changes, right? So as always, ensure your safety, de-escalate whenever possible, and if needed, request law enforcement if they're just too dangerous.
That's right.
Right, and we want you to document when law enforcement is requested, and we also want you to document if law enforcement is either delayed or doesn't show up. That provides some important statistics. We're not building a case to take on our law enforcement colleagues, right? But it's very important. It tells a story about when we needed law enforcement and when we don't, and it kind of helps us in the end. Also, if physical restraint is necessary, I'm going to spend a little time here.
Sure.
Because this is
important.
a soapbox.
This is important.
Soapbox for me, right? This is the one place that you are going to get likely in the greatest risk of your job and your career because it has played out in this country so far. So let's go through that. So if you're going to get into the world of restraining somebody, first of all, make sure you have enough people present. That's very, very important. If law enforcement is present and they're willing to assist, which many of them are, go ahead and have them help you and assist. And then do the big three. All right, I made this up. This is not in any, you're not going to look for this in a journal, right? But the big three. Number one, sit the patient up. All right, why? I'm going to, rather than tell you why, the next time you're out, why don't you go on a few 100-yard sprints and then lay down on your stomach for a while or lay on your back. It's really hard physiologically to breathe, and a lot of these folks are already very agitated. They're very worked up. They're tachycardic, they're tachypnic, they're working to breathe, their muscles are working, and it just becomes really, really hard to physiologically, to meet the physiologic need of breathing when you're flat.
Right.
And so sit them up. It's very important as soon as you safely can to sit them up. And then document. Just document the holy heck out of this. What is their mental status, their lack of response to verbal control, which kind of backs you up about how you went hands-on, threats to any EMS personnel, and then the need for continued restraint. So please make sure you document all of that. And then this is the big one of the big three. Monitor them. Now, I know this isn't going to be easy. If they're sitting and yelling and screaming and spitting and hooting and hollering at you, right, your kind of your assessment is getting done.
Right.
Right. They're conscious. But when your patient gets quiet, that's not necessarily a good sign, right? That's when monitoring is going to come in. Objective data, getting them on a cardiac monitor to trace their heart rate, checking their blood pressure. End-tidal CO2 can help in this situation too. Saturations are going to help. All of that. Get objective data about what's going on with your patient, and so that they don't deteriorate to the point that by the time you realize something's wrong, it's too late.
It's too late. Yeah.
Yeah. So there's your big three. ALS care, you always start with the BLS, right? And so get through the BLS. And then if you're going to, the midazolam doses in our county are 0.1 milligrams per kilogram. And here's the three ways. If you're going to give it IV, you give it in up to 6. 2 milligram increments, right? If you're going to give it IN, you give half in each nostril. If you give it IM, you're going to give it all in one shot in one muscle, unless the muscle mass is too small and you got to break it into.
break it
into two, right? And then again,
monitor all the time.
Yeah, and then just another reminder. Did I say it? Like, please sit them up. Please sit them up. Okay, we're almost there.
We're almost there. We're getting to the final stretch here.
All right. Buprenorphine. Okay, what is it? How does it work? I thought we'd go through a little bit of this. Who should receive it? I won't go into a ton of detail, but basically, when buprenorphine, when an opiate gets in the brain, normally when we have endorphins, we all have endorphins, right? And endorphins kind of give you a little bit of euphoria. Like if you do a big workout and you kind of feel really good after that, it's like a little bit of an endorphin. Like that's a normal stimulation, but when opiates start to get into the brain, or opioids get into the brain, there's an overstimulation of the brain, and that's what can kind of lead to trouble. And then this slide is just a reminder that, but doc, I just did meth. Why did I OD? And I get dope sick every morning, right? Every single morning I wake up and I've got this need that I've got to use this drug again. And that is because, as I mentioned earlier, this sign that's hanging on San Francisco General's doors. I took a picture because I was like, that's brilliant. This should be hanging everywhere, right? Your cocaine and meth are laced with fentanyl. I mean, they are. And that's what's driving them back to this drug.
It's a diabolical push to make those substances more addictive, and so driving dependency on those substances.
Yeah, it's what's driving our dependency. So how does buprenorphine work? You want me to cover this, or you want to?
Sure, I can take it.
Yeah.
So buprenorphine is what we call a partial agonist. So it'll bind onto the same receptor in the brain that your opioid will bind to. But whereas the opioid has a really an unlimited potential for a response, the buprenorphine has a ceiling to it. So it won't cause the same respiratory depression that if you were to take a bunch of fentanyl. But it's binding in a very powerful way. So you're going to have some of the same response like you would from your opioid. There's some analgesia, there's some pain control that can happen there. But the respiratory depression is not as severe. So you're not going to go into respiratory depression to the point where you might die, like you would if you had a fentanyl or other opioid. Now, the great thing about it is that buprenorphine binds to that receptor in such a tight way that other opioids that now come in, if you were to go home and take a bunch of fentanyl, it's trying to bind onto that receptor and it can't get onto the receptor. So it is actually protective from further overdose. So that's why EMS buprenorphine is such a powerful tool for you, the provider, in that not only can you get somebody onto a pathway for getting care that they need with medication-assisted therapy, but you can also protect them from going into an overdose scenario that could kill them.
Right. So we've gone through some of this, but just a quick reminder, some of the more common symptoms of opioid withdrawal is nausea, cramping, anxiety, vomiting, insomnia, irritability, and muscle aches. They just, they feel like they have the flu. That's probably the best description. They're achy, they're vomiting, they might have diarrhea. Like they just feel cruddy. Really, really bad feeling. Yeah. And so those are some of the symptoms. The objective findings you can find, we've kind of gone through this, but tachycardia, diaphoresis, the dilated pupils, kind of the runny eyes, runny nose, that's another big one as well. Yawning, yep. Is interesting.
For a withdrawal symptom, for sure.
Yeah.
It's part of our COWS score that we would use to decide if you're a 7 or above to start buprenorphine.
Yeah. And speaking of that,
there we go.
There's our COWS score. So again, not meant to be memorized.
Right.
But you should know how to use the tool. Our SORT team uses it on electronically. One of our SORT team members found it on an app for free. And so calculated out a COWS score, like I said yesterday, and this lady's COWS score was 34.
And that's one of the ways that you can actually look and see how does your intervention work. Yeah. So you have a COWS score at 40 or wherever, and then you give the buprenorphine and you reassess, recheck that COWS score, and it's improving. That can actually give you an objective indicator that you're doing the right thing.
Yeah, but I want to remind you of something, and that is the use of Zofran. So these individuals, after you give them the buprenorphine, if they're not already vomiting, a lot of them will start vomiting, and so preempting that with some dissolvable Zofran or injectable Zofran, whichever method you choose to use. I prefer dissolvable. There's no reason to really start a line on many of these people. And so, as a matter of fact, if you start a line, you got to stop the line to take them into the TAD program. So let's not do that.
That's right.
Right. So TAD program. But anyway, here's some red light criteria. So the green light was the COWS score. The red light is like if they're under 16, if they've had any methadone use within the last 10 days, that's going to be kind of one that's be a little rare. We don't have a lot of methadone use here anymore. We do have methadone clinics, but I think people are transitioning more over to buprenorphine or the long-acting treatment.
Or Suboxone.
Or Suboxone, exactly. At least they're not getting that from the emergency departments.
Right.
The people on methadone have been on methadone for years,
Right.
and they're still on methadone. If they have any altered mental status to the fact they can't consent, severe medical illness, if they're currently intoxicated or recent use of benzos or alcohol, like these are all risk factors for someone giving them buprenorphine, right? This could make them clinically worse. If they don't have withdrawal, and so those are some of the red light reasons, or if they're just not a candidate for any reason.
And a lot of these folks, this won't be the first time they're in withdrawal.
Yeah.
They'll be able to build rapport, ask them the direct question: Are you using? Are you using pills? Are you using fentanyl? What are you using? And hey, I have a solution for you. And is this how your withdrawal normally is? And a lot of times they'll be able to say, yeah, I feel crummy just like this. And those would be, again, go through your process, evaluate, do all of your ruling out other things, but then that's the person that would be perfect.
Yeah. Don't ever put the blinders on. Always keep your vision wide, right? Don't just jump to it. So how do you give it? You moisten their membranes a little bit, 16 milligrams sublingual.
That's right.
Buprenorphine, and then I talked about administering the Zofran, and then you reassess them after 10 minutes. And if after 10 minutes they need more, you can give them an additional 8. And if you need more than that, you can make base contact, right? It's not uncommon for some of these folks to need 32 milligrams before they're finally starting to calm down. If their symptoms improve, you recommend transport to the ED. This is under the buprenorphine policy, not under the TAD policy. But you recommend transport to the ED or a designated receiving center. Verify their information, reinsure the repeat cows is documented, and then if they don't end up being transported under the buprenorphine policy, for some reason they're going to refuse care, make sure you leave them with the information, the documentation, and leave behind naloxone.
Right.
Very, very important. Okay. Wow. That was a lot. We're going to take, do you want to take a short break and then go into documentation? Or you want to just keep on going?
I think we just keep going. I don't think there's that much to it.
Are you guys bored yet? I don't know. Is anyone awake out there?
All right, so let's talk about triage alternate destination and documentation. So the underlying principle here is to follow your provider agency's training and guidance on this. So for triage alternation for sobering centers or for mental health facilities, strongly recommended, just like we did in our last segment, to use your checklist, the checklist manifesto, to make sure that you're going through and making sure there's no contraindication to the patient going to the facility. If there's a form in your ePCR platform to fill out for that checklist, use it. If there is not, then a recommendation would be to take a photo of it so that it's uploaded with that PCR, so that that checklist is viewable and can be reviewed at a later time if necessary. For buprenorphine administration, strongly recommend using, again, that COWS checklist. So a COWS score greater than or equal to 7 as an indicator for starting somebody on buprenorphine treatment, and then using some type of a method of verifying that checklist. So whether that's an app or whether that's, again, a form that your agency provides on your PCR platform, and then making sure that there's some form of some way of attaching that COWS documentation into your PCR. Clearly document the response to treatment, particularly with buprenorphine administration. We want to see if somebody has a COWS score at the start of treatment of 20 and that your treatment gets them down to 6, 5, 4. We want to be able to celebrate your successes, because like with any other new program, there are detractors from this program. There are people out there that say, you know what, we don't want this in the field. I'm a firm believer that this is successful and will be successful in Sacramento, and we just want to be able to celebrate your success. Okay, so we're still in Module 6 and a discussion on EMS and EMTALA. So I'm sure all of you guys watching, you know what EMTALA is, but it is the Emergency Medical Treatment and Labor Act. Essentially, it was a law that was passed many years ago that just really governed how emergency departments are supposed to be managing patients. You know, we as emergency providers and hospital systems need to be taking all of those patients seriously. We need to be stabilizing medical conditions and getting people the care that they need, and not just kind of dumping them or pushing them off into other areas of our healthcare system. So this was passed in 1986 to address that dumping issue. So essentially, if a patient were to show up and if they didn't have insurance or some other reason why a hospital didn't want to care for them, they in the past were doing the wrong thing. But now the law ensures that our hospital systems are taking care of people appropriately. So there's key points here. So first off, a patient presenting to an emergency department must undergo an appropriate medical screening exam or an MSE. And that MSE must be by a physician or other qualified medical provider. And the hospital can designate who is able to do that MSE.
Yeah, it's actually part of their bylaws.
Part of the bylaws.
Yeah. So it's something I learned is that the federal government doesn't declare who does the MSE. They just say an MSE needs to be done. The hospital makes a decision about who does that. It can be a PA, it can be a nurse, it can be a doc, it can be a nurse practitioner.
That's right. Yep.
It can be a paramedic.
That could be paramedic, yeah. So patients who are found to have an emergency medical condition through that screening exam must be stabilized and treated within that facility's capabilities. Okay, so that's another key provision. And if definitive care can't be offered at that facility, so let's say somebody with chest pain comes in, the medical screening exam is done, and EKG is done STEMI, but if that's a tiny rural facility that doesn't have a cath lab, can't manage that STEMI, then they need to arrange for appropriate care to transfer to a higher level of care for that patient to be managed effectively. So if definitive treatment cannot be provided after stabilization, an appropriate transfer must take place to a facility that has adequate capability. So in that STEMI situation, that patient would need to go to a place that has a cath lab that could intervene on them. If a medical emergency condition has not been stabilized and the patient cannot be transferred unless there's a physician or other qualified person that essentially is able to attest to the fact that the benefit of transfer is greater than the risk of transfer. Because obviously there's a potential for patient decompensation during transport, and if the patient's going to pass or die anyway, and getting them to that definitive care at a tertiary facility or whatever the case might be is the only way for them to survive, that would fall under here. Okay, and then the last one, which I think is the most important for our EMS providers to understand, is that EMTALA is triggered whenever a patient gets within 250 yards of the main buildings of a hospital campus. So a lot of times we talk about the ambulance bay or something like that, but even if that patient's out on the street, on the sidewalk, 250 yards away from your emergency department, EMTALA is triggered, and the hospitals need to be able to go out and to take care of that person. A couple of other things. We don't have any of this in Sacramento County, but these do exist in the state, is that hospital-owned or operated ambulances have an EMTALA obligation to provide a medical screening exam, because essentially that's the hospital that's extended out into the community, because it's a hospital-based EMS provider. So, and also specialized hospitals cannot refuse care. So if it's kind of a tag you're it, I've got a sick patient coming from a small facility that needs to go to tertiary care. If your hospital is able to provide that care, you cannot refuse it. And then before transferring a patient, the sending facility must request that there's the most appropriate EMS level of care to get the person to where they need to be. So if they need ALS level of care, they need to have an ALS interfacility transfer. If they need critical care, they need critical care, etc. And that is the simple walkthrough of EMTALA and EMS.
Awesome. Wow, okay. Only one left.
One left. We'll see you right back here with our triage to alternate destination conclusion.